Good morning. My name is Gottfried Konecny and I'm a professor of medical oncology and gynecologic oncology at UCLA. And I would like to share in this webinar today an update about a new class of drugs which are called Parp inhibitors. Some of you may have been treated with these drugs and some not yet, but I'd like to give you background information and an overview of the clinical data that are available today for this important new class of drug which has really changed the way how we treat ovarian cancer in 2019. I encourage you to ask questions through Twitter and YouTube, and the hashtag number is listed here. Any questions that you submit will then be presented to me at the end of the webinar, and I'll be very happy to answer any questions that you have. The objectives of my talk today are, first, I'd like to review the mechanism of action so that you really understand the value of this drug and how it particularly targets vulnerabilities in your tumor. Then I'd like to chronicle the recent development and the FDA approval of 3 Parp inhibitors that are now available in clinic. I'd like to review how these BRCA mutations can drive your treatment decision in the sense that there are some patients that benefit more and there are some patients that benefit less. And that sometimes is an important piece of information when weighing the benefits towards the risks of a treatment that you are taking. And I'd like to describe best practices of how to manage toxicities, because many of you may have experienced some toxicities with taking these Parp inhibitors on a daily basis. But I do want to tell you there is a way around that, and there are ways that you can take this drug in a safe way without major side effects. First of all, the mechanism of action. You don't have to be a biochemist to understand that, and I'm trying to really give you a broad picture of how these drugs work. In some patients that are diagnosed with ovarian cancer, there is a genetic predisposition which has been well described, and that means that you inherit a gene from your mother or your father that predisposes you to this disease. And they are listed here. And 2 of them may be best familiar to you, that is the BRCA1 and BRCA2 gene, but there are others like RAD51 or ATM-ATR, which are less frequent, but they predispose you to develop ovarian cancer during your lifetime. If we look at a pie chart of patients with ovarian cancer, you can see it's about a quarter of patients that carry these mutations. And there is a distinction between those that carry a germline mutation that you inherit from your mother or your father, or those that actually have that mutation that's in the tumor, only in the tumor and not in normal cells. If we look at the numbers shown here, how frequent are these in a patient cohort that is very typical for Los Angeles, you would see that about 18% of these patients have germline BRCA mutations, and about another 7% have these mutations only in the tumor tissue. That means not in your normal, healthy other cells. So about 1 out of 4 patients have this genetic alteration that can predispose you to the development of ovarian cancer, but most importantly is a very important predictor for excellent response to this new class of drugs. And why? Well, we have many ways of repairing DNA damage that occurs as a natural result of being exposed to sunlight, to any kind of toxins. And you can see these are either classified as single-strand breaks, as double-strand breaks, bulky adducts, or so-called mismatches. And we have a very intricate DNA repair mechanism set up to maintain normal function of cells. The double-strand breaks are very critical for the efficacy of a Parp inhibitor. And the BRCA1 and BRCA gene and associated genes guarantee that anytime the double helix, the hardwired DNA that codes the genes, is broken, gets reannealed and fixed without an error. What happens when you take a Parp inhibitor? Now, Parp does not affect double-strand break repair. It affects single-strand break repair. Parp is critical for fixing a single strand that's broken. If you inhibit that, cells grow and duplicate, and you make a copy of that strand, and suddenly a single strand always turns into a double strand. Not a problem for a cell that has an intact double-strand break repair, because it fixes the double-strand break further down the line. But when you do not have an intact double-strand break repair, you have lost the backup mechanism to repair DNA damage, this first insult becomes what we call synthetically lethal, critical, because you just can't repair that. So using a PARP inhibitor would only kill a tumor cell that has a deficiency in double-strand break repair. In the next slides, I'll show you a few summary slides of what led to the approval of 3 drugs that we now have available. And the 3 drugs are listed here. Many of you may know the trade names better than the generic names: Lynparza, Rubraca, and Zejula, which are olaparib, rucaparib, and niraparib. Olaparib is approved in a couple of indications. One is actual treatment for patients with recurrent ovarian cancer that have had at least 3 prior lines of chemotherapy. Rubraca is approved for patients as treatment in patients that have had at least 2 prior lines of chemotherapy, both in those that have germline or somatic mutations in BRCA. And niraparib is now obtaining its approval, and these data are currently being approved by the FDA for treatment. All 3, in addition, are approved for maintenance therapy. Now, maintenance therapy means when you have suffered a recurrence, you have completed chemotherapy, and your surgeon or your oncologist says, you've had a very good response to chemotherapy. I would like to maintain that. I would like to stabilize that, so I will continue on an oral pill, which is a PARP inhibitor. In this maintenance setting is probably the most common use of PARP inhibitors, and I would think some of you in the audience have been on these drugs or are on these drugs. Now, in the treatment setting, this slide summarizes the 3 PARP inhibitors and the data that led to the approval. These are relatively small studies, between 55 and 137 patients, and you can see that in these patients that received prior chemotherapy, in either 34 or 54% of the patients, the tumor shrank significantly, decreased in size by nearly half. We call that a partial response, or even completely disappeared, such as a complete response. This data was convincing enough to say this is a very active drug in patients that have BRCA1 or 2 mutations, and led to the approval of 2 of these 3 and 1 pending. We've learned a number of things in the past now, and that is where best to use a PARP inhibitor. And this graph depicts the efficacy of a PARP inhibitor in dependence from the number of prior chemotherapy regimens. And you can see from 1 to 6 prior chemotherapy regimens, the more chemotherapy you have, the lower the percent of patients is that responds to the drug, which is described as the objective response rate. You can also see that there's a difference between the black curve and the blue curve, and the black being platinum sensitive, meaning those that responded to prior chemotherapy, overall have higher response rates as opposed to those that are resistant. So response to a PARP inhibitor really tracks to fewer lines of prior chemotherapy, but also the fact whether you're platinum sensitive and platinum resistant. And that led to a completely new development of the drug in the sense that we saw, if you respond to a platinum, you may respond to a PARP inhibitor. And the explanation is quite simple. The efficacy of a platinum, such as carboplatin or cisplatin, depends on deficient DNA repair. You intentionally damage the DNA. If you can't repair it, it leads to sustained tumor cell death and slow recovery. So they both have efficacy based on a very comparable pathophysiological mechanism. And we've used that in these larger studies that are listed here, which led to the approval of PARP inhibitors in the maintenance setting. Study 42, Solo 2, Study 10. Ariel 2 was actually a treatment study, but Ariel 3 was the maintenance treatment with, and the NOVA study with the 3 different PARP inhibitors. I'd like to focus a little bit on maintenance therapy and why do we think it's relevant. Ovarian cancer is unfortunately a disease where you are commonly suffering from a recurrence. Even though initial treatment is very effective, most patients obtain a complete remission, disappearance of any detectable disease. However, it is unfortunately all too often that patients do suffer a recurrence. And it's now known that this can be a recurring pattern, more like a chronic disease. unfortunately, the intervals between these recurrences could get shorter and shorter. So if there is a drug that can extend the time between chemotherapies and change this brief period often significantly, that would be of great value to patients. So the FDA really looked at the progression-free survival as an important endpoint. And I'd like to show you some very intriguing and encouraging data, exciting data, on how we have now changed the treatment landscape of ovarian cancer. These are patients that suffered a recurrence. They have a germline or a somatic BRCA mutation. They were treated with chemotherapy. They obtained a complete or a partial response, were then treated with the actual drug olaparib or received a placebo, so a randomized study. And if you look at the outcome data here depicted in what we call a Kaplan-Meier curve, where you look at starting point, you have 100% of patients that are well, but the further out you move here on the time, you see that the curve drops, so patients do suffer a recurrence. And the quicker the recurrences occur, the quicker the curve would drop. And you see a difference between those that received the dummy drug or the placebo and those the actual drug. The dotted line is the 50% line. That means half of the patients, 50%, suffered a recurrence after just 5 months if they did not take the Parp inhibitor on this study. However, if they took the Parp inhibitor, the median progression-free survival occurred at about 20 months. So there's a 4-fold increase in median progression-free survival, which is highly significant. That means a patient without a Parp inhibitor may have a recurrence after 1 year, but being on the Parp inhibitor, it is now approximately at 4 years. This was now also studied in the frontline setting. That means in patients that were newly diagnosed with ovarian cancer that received frontline chemotherapy and then received frontline chemotherapy after the initial surgery and then received maintenance therapy, either the real drug or the placebo, in the so-called SOLO-1 study. My colleague Kathleen Moore has presented this very recently, and you can see a striking improvement in progression-free survival. Without the pill, at average, there's a recurrence within about 15 months, 13.8 months. With the Parp inhibitor, the average hasn't even been reached. There's about a 4- to 5-fold improvement in progression-free survival in these patients, which is very meaningful for the life of these. Now, I'd like to move on to the efficacy of a Parp inhibitor beyond patients without a BRCA mutation, because it does actually only occur in about 20 to 25% of patients, and the majority do not harbor such a strong predictor. If you remember, about a quarter of patients had the BRCA mutation either in the germline or in the tumor only, a somatic mutation. And the other patients, they're well characterized in the meantime. They have a number of other molecular alterations that may help us inform future treatments. But what's striking is that about 50% of these patients have BRCA-like mutations, other mutations that lead to the same result, that is deficient double-strand break repair. So we now know that it's not just a mutation, but it can be epigenetic silencing. You turn that gene off, it's not functioning. Or it could be mutations in others, such as I showed you on the first slide. Remember RAD51C, P10, and others, PALB2, that can contribute to the same end result. And that is something that we're now doing in the clinic, is that we're studying patients that not only have BRCA mutations, but that have BRCA-like tumors. And you can do that by just going through and sequencing the tumor tissue for the presence of BRCA1 mutations or a long list of others that result in the same end result of inefficient double-strand break repair. Or you can do something which is similar, where you just study what is the end result if you can't break or repair double-strand breaks. Well, then the DNA gets repaired in what we call an error-prone way. It has mistakes. It has duplications, losses. It gets messy, and you can study that. When you line up the chromosomes from 1 to the 22 that you have, you can see on, on the top line, this is not a straight line. There are areas of these chromosomes that are gained and lost. And when you then quantify that, and I'll show you, a patient with a BRCA mutation has a lot of these breaks gains and losses. The gray areas are shaded. Makes up about 15–20% of the DNA. You have someone who is BRCA wild type, has very small areas that have these gains and losses. And then there are the BRCA-like ones. We don't really know what mutations they have, but we see the same pattern. So we can characterize this, and there are tests available now in clinic, such as one from Foundation Medicine, that will sequence your tumor, but it will also give you something that's called homologous recombination deficiency score. So it will give you basically the BRCA-likeness, and the cutoff that has been defined in studies is 16%. So this is something that will not only give you information on the germline mutations, but it will give you more information, and it will more likely help patients beyond those that have BRCA mutations. And I'll show you some of the data. This is the NOVA study. I haven't reported that yet, but it was also a maintenance study where patients received niraparib as a maintenance therapy after chemotherapy for recurrent disease. These are the patients with germline BRCA mutation, very similar, a significant improvement in progression-free survival. There's no question this is an effective drug. But then, these are patients that do not have a BRCA mutation, but they're BRCA-like. They have other mutations that confer the same DNA repair deficiency. This is an effective drug. Not quite as effective in the sense that there's a fourfold improvement in progression-free survival, but there's a doubling. Then there is a group of patients that was actually treated as platinum-sensitive disease that has neither BRCA mutations nor related mutations such as homologous recombination or double-strand break repair deficiency. And here the difference is much smaller. You can see it amounts to just 3 months difference, 3.8 versus 6.9. So there is a gradual benefit of Parp inhibitors. And I think it's important to know how much will you benefit from it, especially when you maybe experience some side effects. These are a summary of what I call the difficult to treat HRD negative tumors. These are all patients that have platinum sensitive disease. Because of the same underlying mechanism, they should respond to a Parp inhibitor, but they don't have a BRCA mutation, and you can see, yes, there is a mild improvement. This was enough to grant the approval for this, but as a physician and patient, I think we have to be sure to give accurate information of how great the impact will be. This is particularly important when we talk about side effects. Now, I would say overall these are well tolerated, but patients can experience significant side effects, and this is unfortunately really fine print, but I'm going to guide you through in detail the 3 Parp inhibitors, rucaparib, niraparib, olaparib. And they're very comparable across Parp inhibitors, except niraparib, which I'll comment on a little more in detail. But the table really summarizes 3 main side effects. One is gastrointestinal side effects, meaning 70%, approximately 70% suffer some nausea. That can be mild. The other main side effect is fatigue. About 70% do suffer from increased fatigue, and the other is about 25% of patients do suffer a drop in red blood cells, anemia, that can occur during treatment. Now, most of these side effects are mild. They're graded as grade 1 to 4 toxicity, and if you focus on the grade 3 or 4, those are the severe side effects. There's a grading system. Severe side effects are very rare. So most patients don't have severe grade 3 or 4 fatigue or grade 3 or 4. However, this is a maintenance therapy. This is given every day, and even a mild side effect can be something meaningful for patients, such as mild nausea. So I think we have to really guide patients through these side effects and address things on a personal level, on an individual basis when we manage toxicities of these drugs, rather than really just looking at the statistics and looking for severe toxicities. If you look at laboratory abnormalities, again, I think drop in red blood cells is the most predominant. For niraparib, the drop in platelets has been described, and I will show you some data how that can be addressed. Other than that, again, it is the fatigue, the gastrointestinal side effects that are mild nausea, sometimes leading to vomiting, and it is the laboratory parameters that change in general that affect the red blood cells, hemoglobin, in some cases with niraparib, the platelets, White blood cells are generally not that affected. There are some less important side effects that affect the kidney value, the creatinine, which can be elevated, but that is not a reflection of renal insufficiency. It is an issue of competitive drug elimination in the kidneys. So your doctor will monitor you for these side effects, but what you can anticipate is to probably experience some mild fatigue and GI symptoms when you start this treatment. Now the key thing is to look out for severe side effects. And it is known that chemotherapy can lead to severe side effects, life-threatening side effects, as do Parp inhibitors. And these are summarized as myelodysplastic syndromes or the acute myelocytic leukemia. And they have been reported with Parp inhibitors because Parp inhibitors inhibit DNA damage and have the potential to be genotoxic. The data shown here are reported for olaparib about 1.5%. That means 1 to 2 patients out of 100 that take a Parp inhibitor could develop myelodysplastic syndrome, and they're very comparable. But it's important to keep in mind that most of these patients have also received chemotherapy, and for chemotherapy, the incidence rate is comparable. And it is probably a mild increase from 0.7 to 1 to 2% when you add a Parp inhibitor. So your clinician and your doctors, they will look out for a delayed recovery in your white blood cells or your platelets or your red blood cells. And if it takes too long for them to recover, they may do more diagnostic tests to screen for these side effects. This summarizes the side effects, again, across the different trials, one with niraparib, the olaparib, and the rucaparib. And you can see in bold, about 70% had mild nausea, 50 to 60% mild fatigue. The anemia was very similar, around 25, 18%, here lower, 7%, and this was the grade 3, meaning they required blood transfusions. Overall, this led to a number that I really want to point out, dose reductions. Nearly 70% on the trial had to reduce the dose. Nearly 25 with olaparib reduced the dose. Nearly 28% on another study, study 19 with the olaparib. And about 55% of patients on the aerial 3 had to reduce the dose. Why? To overcome the side effects that could be fatigue, nausea, anemia, drop in platelets. And this is the critical take-home message. There is a proven benefit in appropriately selected patients for Parp inhibitors. But if you run into side effects, it's not the best advice to stop treatment, but really continue at a reduced dose level, because most of these side effects can be circumvented by appropriate dose reductions. And this just shows you the niraparib study, the NOVA study that I showed you. Starting on month 1, all patients took the full dose, but quickly after 2 months, about half of them had a lower dose, and then going out to 1 year, you see it's about 23 that actually took 2 dose reductions. That's 100 milligram versus 200 milligram and 300 milligram. Despite dose reductions, this retrospective study showed that there was no difference in outcome. So it's safe to say when you take a Parp inhibitor and experience these side effects in an intolerable way, you are already treating at the maximum tolerated dose, and it's safe to reduce slightly lower. There are some quality of life studies that have been reported that show by providing patients with questionnaires that carefully record how they feel. And these studies have not shown, when appropriate dose reductions or counseling has been provided, that there is no decrease in quality of life going out to up to 14 cycles of treatment here. There is one caveat. These questionnaires, however, are built around chemotherapy, and these chemotherapy questionnaires may not capture the daily toxicities as well. So we will be seeing new data that may even do more accurate assessments of quality of life. But it's safe to say that there is no detriment in major life quality when appropriate steps are taken, and these were done in the studies. Now, some of you in the audience may have been treated with a Parp inhibitor. and despite an initial success, have noticed that the drug stopped working or is not working anymore. And we're just learning more and more about this interesting topic about acquired resistance to these PARP inhibitors. And I just want to give you a highlight and summary of some very interesting changes, how the tumor can adapt to this pressure of inhibiting PARP in combination with double-strand break repair. And one of it is about 20 to 25% of patients that don't respond to a PARP inhibitor can develop so-called reversion mutations, that through an coincidental event, the mutation just gets reversed in that another base pair gets introduced. And this is then a clone that proliferates and survives. This can be tested in tumor tissue. This can be tested in circulating DNA in blood. There are other epigenetic and hypomorphic BRCA mutations. There are other now mechanisms that can be upregulated, that can compensate for actually BRCA loss. And we will hear more in the coming years, and we will more importantly use this information to develop novel treatments after you have failed a PARP inhibitor in the diagnosis of ovarian cancer. Other mechanisms are drug efflux pumps. They can be upregulated. They just pump that drug out of the cells immediately, and giving it in conjunction with medications that inhibit the drug pumps, you may be able to increase the efficacy. These are all mechanisms that are leading to novel clinical trials that will be exploring PARP inhibitors in combination with other drugs. And your cancer centers or your institutions around you may have some of these trials open that, should you have benefited from a PARP inhibitor, you may be able to go on to. So in summary, again, PARP inhibition is what we call synthetically lethal. It is a targeted therapy that is most effective in those that have deficient double-strand break repair. There is a tiered efficacy that is most pronounced in those that have BRCA mutations. Those that have BRCA-like mutations, there is a highly relevant efficacy, but somewhat less impressive. In those that are platinum sensitive, but do not harbor a BRCA mutation or BRCA-like mutations, the efficacy is small. And I think it's really an individual decision to say whether you would like to take this pill for that benefit and weigh it against the side effects. I do also think that the drug is less effective in those that have platinum-resistant disease. Simply, these are patients that have less frequent BRCA mutations, less likely to have double-strand break repair deficiency. And it should be carefully thought through if you treat someone with a platinum-resistant disease with a PARP inhibitor. I would advocate for that if there is a mutation in BRCA1 or 2, otherwise not. And again, there are ongoing trials at your cancer centers throughout Southern California that will combine PARP inhibitors with novel inhibitors to restore the dependency that was critical for the efficacy of these pills in the first place. With that, I'd like to conclude my overview. I believe I may be on time, maybe a little late. I apologize, and I'll be very happy to answer any questions that you have. Oh, thank you. I have an iPad here where some questions are listed. I was on a PARP inhibitor and my disease progressed. My doctor is offering me treatment with a different PARP inhibitor. Does this make sense? Yes. So this really ties into the last part of my talk is if you've been on a PARP inhibitor, should you be retreated with a different PARP inhibitor? That may make sense, and I would say under one condition, if you've responded to your treatment with the first PARP inhibitor. And what does respond mean? Well, that means that if you received it as a treatment, there was a shrinkage, or if you received it as a maintenance, if there was a significant duration that you were on the PARP inhibitor, let's say more than 6 months or more than 12 months, that means that PARP inhibitor was effective and may have lost in some sense its efficacy, and retreating you at a later time point, be it as a single agent with a different PARP inhibitor or in combination with another drug, may make sense. If you're asking me whether there are differences between these PARP inhibitors, one better than the other, from a clinical standpoint, there are no head-to-head comparisons. However, the data that are published do appear very similar in the benefits that these different patient populations have, and from a clinical standpoint, I think they're very comparable in their efficacy. There are preclinical data, meaning in the laboratory and in cell cultures, where there are different mechanisms of actions, and it is currently being investigated in clinical trials whether these differences in mechanisms really carry over into differences in clinical practice. And as of today, I don't think there is a better or a worse PARP inhibitor. There are subtle differences in their side effects that can be important for picking one over the other, but we have to stay tuned for further studies, especially regarding the role of a different PARP inhibitor after failure of a prior one. There's another question. I'm on a PARP inhibitor but had to stop the medication because my red blood cells have dropped. My doctors want to put me on a lower dose. Should I continue on my original dose? Yeah, that pertains to the question. If you experience a side effect that we would call more severe, like a grade 3 or grade 4, do you immediately reduce the dose? Generally, if it's the first time, I would hold the drug until the side effects resolve. And I would re-challenge you because you don't want to lightheartedly reduce a dose that may be important. But again, there is no clear right or wrong. It's always an individual case decision. But if you've recovered well, I think it's safe to re-expose you to the same dose. But if it happened a second time that either your platelets dropped or your red blood cells dropped, I would then probably not go back to the same dose and take a lower dose. Considering the data that I showed you, that even with dose reductions, we don't see necessarily, if you dose reduce because of side effects, a decrease in efficacy. Another question, what are the risk factors for taking PARP inhibitors? Risk factors for taking PARP inhibitors, it's a good question. One of these PARP inhibitors has been studied, and that is the niraparib in the NOVA study. And a retrospective analysis showed that patients, when they started taking the PARP inhibitor that weighed less than 77 kilo, meaning were lighter, were at higher risk to develop a drop in their platelets or side effects. Also, patients that started out at baseline with platelets lower than 150,000 were more likely to develop severe thrombocytopenia. So the guidelines have come out, and however, this is not an FDA-approved guideline. This is more or less a clinical recommendation to safely give the PARP inhibitor if your platelets are below than 150,000 or if you weigh less than 77 kilo. You would usually start at a lower dose of niraparib, 200 versus 300 milligram. This does not apply to the other PARP inhibitors, olaparib or rucaparib. So far, we have not seen data like this. Now, the FDA will not use this as an on-label dosing recommendation until they've looked at the data that are now maturing and that will be presented in about 2 weeks in a meeting in Barcelona, where this dosing schedule has been prospectively studied, meaning looking forward. Patients were on different doses and they're looking to compare the efficacy. But it's a real world. We're out there, and you want to give the drug safely. So if you're using niraparib, you want to be careful if the platelets are low when you start or if you're of lighter weight. I hope that answers your question. Do we have any more questions? No? Then I would very much like to thank you for joining the webinar and submitting questions. I hope it was a little helpful for you, and I very much look forward to being back. Thank you.